If you're working in the urgent care center, you know that you're swamped with influenza. And a question came up from one of our subscribers about antiviral therapy and testing and what the best protocol is for putting all that together now in the 25-26 season for influenza. So as a quick summary, you already know that right now the circulating predominant strain is H3N2. It's a variant of influenza A, and unfortunately, it's not very well matched to the vaccine. So we're seeing a lot of illness in all populations, children and adults. 90% of the US cases are of that subclade K H3N2 variant, and the flu positivity test rate is 18%. Doesn't seem like a high number, but it actually is quite high. Comparatively, COVID-19 positivity is at about 5%. So kind of a very low seasonal number compared to where influenza is right now. And that probably matches very well with your clinical practice. So when we're talking about urgent care and a testing and treatment algorithm, the CDC has some good tools out there for us. And one of the common ways to go about addressing this is empiric treatment, meaning if you're in the urgent care setting and your clinical judgment says, okay, this is influenza, you can just go ahead and treat. You don't have to test this person. You can start antivirals, especially in people who are high risk. And that high risk category includes anyone who's over the age of 65, anyone who was under the age of 5, especially those under the age of 2, anyone who is pregnant, anyone who is within 2 weeks of delivery, so 2 weeks postpartum, and anyone who has asthma or COPD or heart disease or diabetes or is immunocompromised. And I don't know about you, but that's a large swath of the urgent care population. So you're very likely to see someone who's considered high risk. And if they are high risk, you should be treating them for influenza. What if we are obtaining testing and the testing is negative? Well, the CDC says if your clinical suspicion is high, then go ahead and treat them, and the testing becomes irrelevant because some of the tests out there, depending on which kind you're using, have a very low sensitivity, and that brings us really into this gray zone where we have to compare our clinical gestalt, or how concerned are we that this person actually has influenza, with their risk status, and then try and correlate the test result. So if they're in that high risk category and you think they have influenza, go ahead and treat them. You can test, you can even send off a definitive test, but don't withhold treatment waiting for a test result. And that brings us to the next question, which would be, okay, if I'm supposed to use my clinical judgment to try and differentiate influenza from something else, and even in, for example, the face of a negative test, what is that supposed to look like? How do I use my clinical judgment to make that decision? And the answer to that is there are some things, some general guidelines you can use. First of all, the predominant virus out there spreading through the country is influenza. So if you have a respiratory virus, there's a really good chance it's influenza right now. That helps. Second, the influenza virus tends to be more of a sudden onset and less of that slow, insidious creep that you might see with COVID or other just general colds. Third, influenza has a more rapid onset of high fever, intense myalgias, maybe profound fatigue, and the patient who felt fine at breakfast might all of a sudden be bedridden by lunch. All of those are indicative that this might actually be influenza. And like I said before, context matters. Now, in February 2026, the predominant strain of any virus is influenza. And with the test positivity rate being that high, chances are really good this is the flu. How do you differentiate it from something like a cold or COVID-19? Well, COVID-19, speaking very generally, has a slower onset and comes with some very key specific details, things like prolonged fatigue, new loss of taste or smell. If that's present, it's probably not the flu. If it's just congestion in the nose and there's no other associated symptoms, well, that's probably the common cold. But the good news is that we have testing that can differentiate some of those, especially the important ones. So for example, tests nowadays, or multiplex tests as they're called, can differentiate influenza A and B and COVID-19. So if you're working in an urgent care setting and you're wondering, okay, how reliable is my test? That brings us to the next category, testing. Testing falls generally into two types: the rapid antigen tests. So this is detecting part of the nuclear proteins on the outside of the virus. And then there is the rapid molecular category of tests. So these are NAATs, or nucleic acid amplification tests, and they include the things like rapid molecular tests and PCRs and all those things that are much more reliable. The antigen tests that detect the actual presence of the virus by detecting nuclear proteins generally take 10 to 15 minutes to run, and they have a very good specificity, meaning if they're positive, chances are really good that's what you got. Their specificity runs 90 to 95%. So if it's a positive test, you're good. But the sensitivity isn't that good, meaning it's typically 50 to 70% sensitive. So if it's negative, you can't really say they don't have it, especially when most of the community around is suffering from the same virus. The problem is that these rapid antigen tests are the cheapest, and they're the ones that are the most available, and they're also over the counter. So people might come in with one of these tests at home saying, I've taken one, it was negative, so I don't have the flu. And the answer is, it's probably not true. You very likely have the flu given where we are in context of the season. It's just that that particular test isn't very sensitive. Hopefully in your center, you have one of the nuclear amplification or molecular tests, and these can still be rapid. There are rapid versions of them, which will result in 15 to 30 minutes, but they come with much higher sensitivities. We're talking like 90 to 95% sensitive, 90 to 95% specific. That's very, very good. And you can rely on that test to say, yes, they have it, and yes, they don't. And furthermore, they usually test for multiple things. So you're looking at flu A, flu B, and COVID. You can settle that debate by just walking over to your lab and looking at the product that you have. If it says NAAT, or if it says rapid molecular test, then you know that's the more reliable version. If it has the word antigen in it, like rapid antigen test, that's the one that's less sensitive. So if it's negative, you can't rely on it as much, but if it's positive, you can. And then there are the lab grade PCR tests. Most urgent care centers are not running these. These are larger machines. They can take 45 minutes to a few hours before they give you a result. And if it's a send out lab, you're not going to get it back for days. And the CDC recommends that all of these medicines, these antiviral medications we're going to talk about in just a minute, are prescribed within 48 hours of symptom onset. That's how the FDA has approved them. So you don't have time to do a send out test. You have likely already lost a day with the patient waiting at home to see if they get better. And now that 48-hour window is shrinking quickly. So you could do a rapid test in your urgent care. There's very little time to send out. And this is where your clinical setting and your examination and your suspicion and whether or not they're high risk begins to matter. All right, let's quickly touch on treatment. So there are 4 approved antiviral medications currently. This is February 2026 for influenza, the big 4, as we like to call them. Oseltamivir, or Tamiflu, is the one that's been around forever. Baloxavir, or Zoflu, is a newer antiviral agent. Zanamivir is also an inhaled new antiviral agent. And Peramivir, which is available really in hospitals, is given IV. So you're likely going to be debating between Tamiflu and Xofluza, or oseltamivir or baloxavir. Both of these are oral administered. They do come in little packets and in liquids and ways to dispense to children. And there are some important things to remember. So oseltamivir is the old workhorse that we've had around for quite a while, and it's approved for all ages. Infants, even newborns, are given it in the hospital. It is the preferred choice for pregnant and breastfeeding patients. It is a 5-day course, and it does come with pretty common GI side effects, nausea and vomiting. So that's what most of us have seen in clinical practice. Baloxavir, or Xofluza, works similarly, but is a single dose given once. Still has to be given in that 48-hour period. It is the same kind of antiviral therapy. There are some head-to-head studies that say, yes, it probably results in symptom resolution sooner, but overall, it's very, very similar. The big thing about this medication is it's a one-time dose. So if it's a patient compliance problem, it's very easy to just take a pill once, and it has less of the GI side effects, but it can be more expensive. It may not be covered by their insurance, and your local pharmacy may not have it. So there are those variables you have to keep in mind. It is approved for ages 5 and up, so not quite as young as oseltamivir. And even though it's convenient in dosing, it doesn't have approval in pregnancy. It doesn't have approval in breastfeeding patients. We don't have enough information there. And if someone is severely immunocompromised, there is some evidence that says they should be on something like oseltamivir because those patients can shed virus for a very long time. And that particular measuring point is better with oseltamivir. All right, let's talk about zanamivir with a Z, also known as Relenza. This is actually an inhaled antiviral medication, and it works directly in the lungs. The idea is that it will clear the virus more rapidly because it's going directly into the respiratory system, and it has less overall side effects because you're not having to absorb it through your gut and then get systemic absorption. It is a multi-day dosing regimen, and it is not to be given to anyone who has lung disease. So we're thinking asthma, COPD, any kind of history of bronchospasm, completely contraindicated in those patients. But it is an option, especially if, GI tolerance is an issue or if there's allergy to previous antiviral therapy. It does tend to be expensive, but there may be some insurance coverage there. And lastly is peramivir, also known as Rapivab. And don't get confused, even though it's known as Rapivab with an AB at the end, it is not an antibody. It is an antiviral medication, but it's given IV only to hospitalized patients as a one-time dose and is not something you're going to give in the urgent care. So really that leaves you with 3 choices: Tamiflu, Xofluza, or Relenza. So a multi-dose oral therapy, a single-dose oral therapy, or an inhaled medication. So what if our patient has renal disease or is on hemodialysis? Oseltamivir and peramivir both have renal adjustments that have to be made for dosing. Baloxavir, the one-time dose, and zanamivir, the inhaled medication, do not have renal adjustments that are necessary. So you have to keep that in mind. You got to look it up. And if they're immunocompromised, there is a recommendation from the CDC where they prefer oseltamivir over baloxavir because of that prolonged viral shedding. That's a lot of information I threw at you during this video. If you want the written summary, that link is provided for you in the notes, and all of that information will be available to you for the rest of the season. Good luck out there. Wear your masks and wear your gloves and be safe.